Hey class, as we look at our vasoreflexes, the purpose of our vasoreflexes can be multifold. We need our vasoreflexes, those reflexes are our blood vessels, to control the dilation and constriction of our blood vessels. And this is going to allow for us to have, number one, general control of our blood pressure, and then number two, reroute blood to where it needs to go in our bodies. So as we look at this method, we can find that we can raise or lower blood pressure with our whole body, or we can redirect it to specific parts of our body. For instance, let's say you just ate a big meal. After you eat that big meal, we're going to initiate our parasympathetic response of our nervous system. And that parasympathetic response of our nervous system is going to redirect blood towards the digestive tract and away from skeletal muscle tissues. It's going to help us to have what we often refer to as the food coma. We have that sleepy feeling where we generally want to relax a little bit. And that's a very appropriate rerouting of blood from one region of our body to another region. When we look at general control of blood pressure, to generally increase blood pressure in our body means that the medullary vasomotor center is going to have to be upregulated. And we're also potentially going to have widespread circulation of a hormone like angiotensin 2, for example. And this is important. We need to have a minimum blood pressure, particularly in our brain, so that we can have cerebral perfusion. So in other words, so that we can allow for our brain to have enough enough nutrient exchange, even if we're experiencing blood loss through a hemorrhage or fluid volume decrease of our blood because of dehydration. Another method of rerouting that's very important is when we're activating our sympathetic nervous system. So in the previous slide, I talked about parasympathetic activation. On this slide, let's focus on sympathetic activation. When we are getting ready for physical activity, we downregulate blood supply to the intestinal tract and upregulate blood supply to our skeletal muscle tissue. And we can control this either regionally or centrally, or with our brain, or at the local tissue level. And as we activate our sympathetic nervous system is also going to downregulate blood flow from the kidneys. So we downregulate, one moment, Ben, I'm making a recording. Where was I? Okay, so we also, in addition to downregulating blood flow to the digestive tract, downregulate blood flow to the kidneys so that we have a decrease in urinary output. We also find that we can have metabolite accumulation in tissues. The metabolite, in this context, when we think metabolite accumulation, we're thinking the buildup of waste products. And as we have waste products build up in tissues at a local level, we can upregulate circulation to those tissues without affecting circulation to other tissues of the body. Now, as we look at the walls of our capillaries, the walls of our capillary also aid with exchange in our bodies. They're uniquely designed to maximize the rate of exchange. We have a simple squamous epithelium to the tunica intima of the capillaries. And this exchange is two-way movement of fluids. We deliver needed nutrients and we remove unwanted waste products. So as we look at these things that we move around through our capillaries, they include water, oxygen, glucose, amino acids, lipids, minerals. You get the idea. Lots of different things are moved around either into or out of our capillaries depending on concentration gradients and pressure gradients. And these different substances, these different chemicals can get in through the capillary wall three different ways. We can have endothelial cell cytoplasm, so they can go directly through the cell through diffusion or transcytosis. We can have them move through intracellular clefts between those endothelial cells, or we can have filtration pores, which are fenestrations within our fenestrated capillaries. So, class, as we look at diffusion in and of itself is the single most important way that we have things get in and out of our blood capillaries. So when we look at simple compounds like glucose and oxygen, Those two chemicals are almost always going to be more concentrated in the blood and tend to diffuse into the extracellular fluid. And conversely, carbon dioxide and waste products are almost always going to be more concentrated within the extracellular fluid and will diffuse into the bloodstream. We also have lipid-soluble substances. These lipid-soluble substances are chemicals that can go through a phospholipid bilayer very quickly or easily. They include steroid-based hormones, an oxygen molecule, a carbon dioxide molecule. These are both nonpolar molecules. They can go straight through the plasma membrane. We also have water-soluble substances like electrolytes, which for review are dissolved ions. Sodium, potassium, calcium, and chloride are among the most common electrolytes. We also have glucose as a dissolved electrolyte, and those larger molecules or charged molecules need to pass through a filtration pore or an intercellular cleft within the endothelium. Very large molecules, like proteins, are blocked and kept in the bloodstream. And that's very important for maintaining our osmotic pressure within our blood, our colloid osmotic blood pressure. Let's talk about transcytosis. To review from AMP1, during transcytosis, we are going to have endocytosis paired with a transport vesicle paired with exocytosis. So the chemical compound is engulfed by the cell and then ejected by the cell during transcytosis. It has to travel across the cell via a transport vesicle. This method of transcytosis is very important for tightly regulating what can get in and out of the bloodstream for larger things like proteins that normally can't cross, or some protein-based hormones, or some specific fatty acids that have more difficult time diffusing across the plasma membrane. As we look at filtration and reabsorption, the fluid that's being... Sorry about that. I just lost my train of thought. I had to pause my recording while my kiddos needed some attention. So let me restart on this slide. So when we're looking at filtration and reabsorption, having fluid filtered out of the fluid will leave the arterial end of the blood vessel. So on the side of the blood capillary bed that's closest to the arteries, the arterial end, we have a net movement out of the blood capillaries. And then this fluid that's leaving on the arterial end is pushed out with hydrostatic pressure. And then on the venous side of our capillary bed, the side closer to the venules and veins, we have osmotic pressure pulling liquid back into the bloodstream, having a net movement of fluid back into the blood capillaries. And on the arterial side, we deliver materials that are needed for the cells, and on the venous side, we remove metabolic waste products. And as we look at these hydrostatic and osmotic pressures, they're opposing. The hydrostatic pressure is always going to push fluid out of the capillary bed. We have more hydrostatic pressure on the arterial side, less on the venous side. And conversely, osmotic pressure pulls fluid into the capillary beds. And that's because of those blood proteins, such as albumin, that remain stuck in the blood plasma. So as we go from the arterial side to the venous side of the capillary beds, hydrostatic pressure decreases and osmotic pressure increases. So once we get to the venous side of the capillary bed, the osmotic pressure overpowers the hydrostatic pressure, and we have a net movement of fluid back into the bloodstream. This is referred to, can be summarized with oncotic pressure as well. As we look at oncotic pressure, it's the overall colloid osmotic pressure. So we take the osmotic pressure of the bloodstream minus the osmotic pressure of the tissues, because we also have osmotic tissue pressure with our extracellular fluid. And this oncotic osmotic pressure on the venous side of the capillary beds needs to draw fluid back into the veins to help prevent fluid from building up within our tissues, to prevent the edema from occurring. So here's a chart that better illustrates this, or figure. On the artery side, or arterial side, we have lots and lots of hydrostatic pressure. And that hydrostatic pressure is going to cause an overall net movement of water out, or fluid out of the bloodstream on the arterial side. And then if we look on the venous side, the overall hydrostatic pressure is rather low because we've just lost a whole bunch of fluid and blood pressure has gone down. Conversely, on the venous side, because we've lost so much fluid on this side from hydrostatic pressure, by the time we get to the venous side, the albumins and blood proteins have become more concentrated, and that causes there to be a dramatic increase in our oncotic pressure relative to the other end of the capillary bed. Even though these numbers are looking about the same, I want you to internalize it as the blood proteins being more concentrated on this side. So we have an increase in oncotic pressure relative to hydrostatic pressure, and we have a net movement of fluid into our blood capillary beds on our venous side. So that's all we have for this recording. If you have any questions or comments, please feel free to post them in the class discussion board or to shoot me an email. And as always, happy studies.